Today we're going to walk through the Model Uniform Core Criteria, or MUCC, for mass casualty triage. I'll refer to MUCC as MUC for the rest of this lesson. These are 24 core elements that any mass casualty triage system should have, whether it's SALT, START, Jumpstart, homegrown systems, or what we use in our own system RAD. A CDC working group created the criteria so that there was a framework for systems in the country to follow when creating their own triage model. Think of MUC as the checklist for what good triage looks like during an MCI. Our goal is not just to memorize them, but to understand why each criterion exists, how to apply it in the field, what can go wrong if we ignore it. We'll go through each with examples and discussion. At the end, we'll tie them together in a few quick scenarios. Starting with the first criterion. This means that in a disaster, your triage system must work for everyone: newborns, children, adults, elderly, pregnant patients, people with disabilities, language barriers, or cognitive impairment. You don't get a separate triage system just for kids or just for adults. In practice, this means the steps, colors, and categories are consistent across all age groups. You might modify interventions slightly depending on the patient, but you're not switching to a completely different triage logic halfway through an incident. Why does this matter? In a large-scale incident, you'll have mixed populations. If one engine uses one system for adults and something totally different for kids while mutual aid uses yet another, you lose interoperability and waste time arguing instead of treating. The goal is to eliminate confusion, miscommunication, miscategorization, and transport mix-ups. This type of scene will already be hectic. There is no need to make it crazier. The triage system must function whether the incident is a school bus rollover, a nightclub fire, an explosion at a factory, a train derailment. What they all have in common is multiple patients in one location. MUC doesn't care about the cause, just that your system reliably sorts patients in any of those settings. We're not designing special triage rules for shootings versus tornadoes. We're using one approach that fits any multi-patient event. In an MCI, you're stressed, cold, tired, maybe in the dark, maybe being yelled at. You will not remember a 15-step algorithm with sub-branches and complex math. MUC demands that triage systems be simple, minimal steps, clear logic, memorable. You can recall it from stress memory. Supported by aids, pocket cards, helmet stickers, triage tags with algorithms, posters on engines. Our system uses RAP, Rapid Assessment of Mentation and Pulse. Do they follow commands and do they have a pulse? Doesn't get much more simple than that. Austere means non-ideal. Poor lighting, weather, debris, loud noise, limited equipment, unstable structures. Your triage system can't require continuous monitoring, quiet environment, full equipment layouts. Instead, it relies on hands, eyes, and a few simple tools. We might have to split up as a crew, so being able to operate in these environments oftentimes alone for a few minutes is key. Triage is always performed in the context of resources available at that moment. A patient who would be immediate in a well-resourced setting might become expectant if you have 0 ventilators and hundreds of patients. MUC requires that the system allow triage categories to shift when resources change. Consider both patient condition and system capacity. Once you assign a category, it must be obvious to everyone. Color tags, tape, tarps, armbands, something that is quickly seen even at a distance. This allows command to estimate patient load by color, transport officers to quickly select who goes next, incoming crews to immediately orient themselves. Triage is not a one-time label. Patients can deteriorate, improve after interventions, change category when new resources become available. MUC insists we plan for retriage, especially before transport and during prolonged incidents. The CDC likes to global sort, so Instead of immediately dropping to your knees with the first patient you see, Muck wants you to sort the crowd first using simple commands like, if you can walk, go to the parking lot by the fire engine. If you can hear me, wave your hand. This quickly divides patients into groups and buys you control and chaos. This might be something that you use in the back of your mind, but is not part of our ramp model. Once you've globally sorted, your first hands-on priority is the group most likely to die without immediate intervention, cannot follow commands, no purposeful movement, obvious life-threatening external hemorrhage. These are the people who may benefit from tourniquets, airway maneuvers, decompression, etc. right now. Second priority are patients who cannot walk, but can. Wave, squeeze your hand, nod yes/no, follow simple commands. They are more stable than the first group but still need attention before the walkers. Your last priority is the walking wounded, those who can move on their own and don't appear to have life-threatening bleeding. Important note, this does not mean they are uninjured. They may still have fractures, minor bleeding, or even internal injuries. They simply aren't your first individual assessment group. Just because someone walked doesn't mean they're fine. Muck requires that every patient gets an individual assessment as soon as resources allow. This step catches internal bleeding, slowly developing respiratory compromise, hidden injuries under clothing. Criteria 13, 14, and 15 are together and deal with life-saving measures. In an MCI, you can't spend 10 minutes on one patient. Muck says you can only perform LSIs that use equipment you already have on you, or in your scope of practice, can be done in under 1 minute, don't require you to stay with the patient afterward. Good LSI examples: tourniquet, opening and airway, needle decompression. Not appropriate in initial triage. 4-axis and full fluid resuscitation, detailed wound care, splinting long bones. The medical directors in our system have also established life-save measures in our ramp protocol. They say that if time and resources are available, you will perform these in order to buy the patient some time. Muck standardizes 5 categories: red/immediate, critically injured, need rapid intervention and transport, yellow/delayed, serious but can tolerate a delay, green/minimal, minor injuries, can wait, gray/expectant, likely to die with current resources, but may receive care if resources free up, black/dead, no signs of life after allowed interventions. This is where our system gets even more simple. We have green, red, and black. You will be assessing these patients once in the treatment area and determining which greens are more of a priority for transport once the reds are gone. In initial MCI triage, you do not count respirations or pulses. You don't time cap refill or check a blood pressure. Instead, you use binary questions. Is the patient breathing? Is there a radial or peripheral pulse? Are they following commands? Is there life-threatening bleeding? This keeps you fast and consistent. With RAMP, we spend 30 seconds at each patient just asking simple questions to assess our patient. No monitors, no SpO2, no glucometer, no EKG, no Doppler. None of that during initial triage. You simply don't have time or equipment for dozens of patients at once. You can add diagnostics later during treatment and transport phases. Cap refill can be affected by cold, age, skin tone, lighting, and is not reliable on its own. Muck states you cannot base triage solely on cap refill. Better quick indicators are presence or absence of a peripheral pulse, mental status and ability to follow commands, obvious signs of shock such as severe bleeding or respiratory distress. Leaving a patient to die is ethically and emotionally tough, Muck says. If a patient is apneic, you do one airway maneuver. If they still do not breathe, they are tagged black/dead. Why? Because in an MCI, staying with one non-breathing patient for prolonged resuscitation may cost several other salvageable patients their lives. As part of the Muck and not our system, a patient is immediate/red if they have any of the following and are potentially survivable with current resources. Can't follow commands or no purposeful movement, no peripheral pulse, obvious respiratory distress, life-threatening external bleeding. These are your top priority for rapid intervention and transport. Expectant/grade patients look like immediate in terms of severity, but with your current resources, they are unlikely to survive. Examples might include massive head trauma with brain matter exposed and agonal respirations, multiple severe injuries when you already have dozens of other critical patients, and very limited transport. They are not ignored. Unlike Black, they get comfort care and may receive more if resources open up, but they are not first in line for transport. Delayed/yellow patients are sick or significantly injured but can safely wait a bit. They can follow commands or make purposeful movements. They have a peripheral pulse, no obvious respiratory distress, no life-threatening hemorrhage. Injuries are significant but not minor, like long bone fractures, moderate burns, stable abdominal pain. They need treatment and transport, but after the rest, minimal/green patients or you're walking wounded, following commands, good pulse, no respiratory distress, no life-threatening bleeding, only minor injuries such as scrapes, small lacerations, ankle sprain, minor burns. These patients can often assist in their own care, help with other minimal patients, free up rescuers to handle more severe cases. Just remember that these colors are part of MUC and not our ramp system. MUC doesn't tell you a specific brand of triage like SALT versus START. It tells you what a good triage system must do. As EMTs and paramedics, you should be able to recognize whether your system is MUC compliant, apply these criteria under stress, and re-triage as conditions and resources change. In a disaster, this is how we save the most lives with the resources we have. The next slide will have our ramp model on it. Pause the video on that slide and discuss whether our system is MUC compliant and what big differences our model has to the CDC suggestions. This will be the end, so have fun.